Hi everyone, we're going to talk about respiratory disorders in Chapter 32. Let's briefly go over a little bit of things that we know already. For the anatomy and physiology of the upper respiratory tract, it's comprised of the nasopharynx, the nostrils, the larynx, upper part of the trachea, eustachian tubes, and the sinuses. The lower respiratory tract includes the trachea, the right and left lungs, the bronchioles, alveola, and the bronchi. To have a airway disease, we know that lung disorders have some form of airway obstruction, whether that's an intraluminal caused by secretions, debris, or tumors, thickening, contraction of the smooth muscle, or any extrinsic compression. Obstruction can be either complete with no airflow, drainage of secretions, partial where there's impaired airflow and some drainage of secretions, and then the obstruction can be impacting where it's located. If it's an above the bronchi, that can interfere more with inspiration. You'd have stridor, and a lower obstruction, you could have wheezing during expiration. Restrictive processes are less common in kids. The body has several defense systems in place to help with our breathing, which include mechanical and biological processes. Mechanicals including filtering particles, humidifying and warming the air, clearing the air with coughing changes, and any spasm or breathing changes. And some biological processes include phagocytosis, the absorption of toxic gases, and the absorption of particles into the lymph system. When we go to assess the respiratory system, there's a mnemonic that is beneficial when you're conducting your history. So it's the PQRST mnemonic, P meaning promoting, preventing, precipitating, and palliating factors. People that the child may have been in contact with, any preventative measures such as medication, supplements, hand washing, progression, whether the symptoms have increased or decreased in severity, and what treatments have been used at home. Q would be for quality or quantity, how severe are the symptoms. R would be for the region or radiation. Are there complaints to the chest? S includes severity, setting, simultaneous symptoms, similar illnesses in the past. And T are those temporal factors. When did the illness begin? Was it acute or was it insidious? How long has it been going on? Other important factors in your history include family history, review systems, and any environmental concerns. And on your physical exam, of course, you're going to be checking vital signs, general appearances. You're going to look at the head, nose, throat, the pharynx, the tonsils, the chest. You're going to palpate and percuss the chest and auscultate. Diagnostic tests that you may do based on history and symptoms. Very easy in the office would be a pulse ox. You could also do blood gases, imaging, sweat testing or cultures, and then also refer to a pulmonary specialist if needed. In this slide we have some basic management strategies for maintaining our airways in little ones. We know that fluid and hydration are very important, making sure that they're receiving good oxygenation, humidification. If it's a little one and they have congested nasal passages, a bulb syringe, and then also the use of normal saline, nose drops, rinses, sprays, etc. Other medications that may be brought in would be antibiotics, analgesics, antipyretics, decongestants, antihistamines, cough medicines, and expectorants. Other management strategies include frequent hand washing, monitoring for exposure to secondhand smoke, coughing into the elbow or into a Kleenex. And then if you review box 32-1 in the book on page 798, key characteristics of cough, common causes and questions to ask during a pediatric history, it gives some good information to include in your pediatric assessment and things to ask parents about. And finally, before we get into the specifics, indications for tonsillectomy and adenectomies. As you can see on this slide, the current guidelines were from 2011. When I did go researching further to see if there were updated guidelines, there were new guidelines that were released this year that were an update to the 2011 guidelines. Those have been posted in Blackboard, but to summarize briefly, they say to still follow these numbers for based on infections in the past year or the past couple of years. The new guidelines talk about the use of antibiotics prior to surgery, talk about the use of ibuprofen and Tylenol or both for pain control after tonsillectomy. They give more detail for the child that has obstructive sleep disorders and what should be done before surgery for that. So I encourage you to look at those guidelines. They're 19 pages long, but the information that you need is right there in the first 2 pages. It's very clear cut. So let's talk a little bit about upper respiratory tract infections. Our first one is the common cold, and in little ones, we know that they can have an average of 6 to 10 of these per year. They may present with a little bit of low-grade fever, runny nose, and it typically resolves around the 10th day, typically caused by viruses, the para-influenza, RSV, coronavirus, or the human metapneumovirus. If little ones are in daycare or preschool, they have increased rates. We know that the virus can attach to the cell receptors in the nasal mucosa. We can see nasal congestion, coughing, sneezing, runny nose, fever, hoarseness, pharyngitis, and symptoms typically resolve in about 10 days. Usually there's a gradual onset. It's mostly nasal symptoms. There may be some sore throat, a mild cough. Secretions may be a little purulent after 1 to 3 days. There can be some redness to the conjunctiva. The mucosa can be red to the nasal passages. Secretions can have different colors. There can be mild redness to the throat. There may be anterior cervical lymphadenopathy, but these lymph nodes move easily. Lung sounds are clear. Some of your differential diagnoses may include allergic rhinitis, rhinosinusitis, adenoiditis, and the treatment for the common cold is supportive care, symptom relief. And then you just need to make sure parents are aware if there are any secondary bacterial infections, such as ear infections, pneumonia, or sinusitis. So let's move on to more throat issues. The first one we're going to talk about, or we're going to talk briefly about pharyngitis, tonsillitis, and tonsillopharyngitis. So we know that pharyngitis is the swelling of the lining of the throat, which can include the tonsils, the pharynx, the uvula, the soft palate, and the nasopharynx. Sorry about that typo there. It's usually acute with redness, exudate. There may be some ulcerations. It could be viral or bacterial. It can have many different causes. On our history, the patient may report pain, myalgia or arthralgia, some fever, sore throat, difficulty swallowing, runny nose, cough, hoarseness, sores to the mouth. It has a gradual onset. On clinical exam, the throat may be red. That may include both tonsils and the pharynx. There may be some cervical lymphadenopathy, and symptoms can be specific to the virus. So if it's the EBV, you may notice some exudate on the tonsils and the soft palate. If it's the adenovirus, there may be a follicular pattern on the pharynx. The enterovirus, you may notice vesicles or ulcers. Herpes simplex may have ulcers anteriorly with adenopathy, and the parainfluenza and RSV, you may notice more issues on the lower tract. Testing may include the rapid antigen detection test or cultures, and then also if symptoms indicate, you might do a group A beta hemolytic strep screen. Management for these symptoms are, for the viral symptoms, are supportive and good fluid intake. For bacterial concerns, it's important to get a good clinical history. Typically, it's between 5 and 13-year-olds. There's an abrupt onset with no nasal symptoms. You may have the aches, headache, a moderate to high fever, malaise, sore throat, difficulty swallowing, some GI issues, and is very common in late winter and early spring. Physical exam could indicate some petechiae on the soft palate. The tonsils and the uvula are beefy red. There's edema noted. Drainage may be yellow and blood tinged. Lymph nodes may be tender, bad breath. A scarletiniform rash can appear, and it's that diffuse redness of the skin with small papules. There could be a strawberry tongue. There are several diagnostic studies that can be ordered based on symptomatology. The RADT, you can order anti-streptococcal antibody titers. If mono was suspected, you'd want to order a CBC and a heterophile antibody testing. Management would include antibiotics in symptomatic children and those with positive test results. Page 805 in the book gives good information for antibiotic therapy. You would be offering supportive therapy. Steroids are not indicated, and the child is able to return to school when they've been fever-free, when they've been on antibiotics for 24 hours. There can be several complications of these conditions. If a child has had strep, they could have rheumatic fever, post-streptococcal arthritis, acute glomerular nephritis. Those that are less than 6 may have retropharyngeal abscesses. There is also a condition called PANDAS, pediatric autoimmune neuropsychiatric disorder syndrome, that can happen after strep, after this exposure, where you will see obsessive compulsive tendencies or a tic disorder, a prepurital onset. These can happen quickly. There is a clear association with group A beta hemolytic strep, and there can be some neurological abnormalities. Let's talk next